This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending neurosurgeon.
And I'm Dr. Lara, a research fellow. Today we're looking at a fascinating new study from the journal Neurosurgical Review, published in 2026, titled Rigid Sellar Floor Reconstruction in Transsphenoidal Surgery, Prevention of Cerebrospinal Fluid Leakage Attributable to the Water Hammer Effect.
This is a topic near and dear to any transsphenoidal surgeon's heart. Postoperative cerebrospinal fluid, or CSF, leakage remains one of the most challenging complications of transsphenoidal surgery, or TSS. We've all been there. The surgery goes beautifully, but then you're dealing with a postoperative leak that requires a trip back to the OR.
Exactly, Dr. Aris. The study, led by Dr. Kosaku Amano and colleagues at Tokyo Women's Medical University, covers a massive retrospective analysis of 1,168 consecutive TSS procedures performed by a single surgeon over a 20-year period, from October 2004 to March 2024.
That's a significant volume. It gives us a very clear look at how reconstruction techniques have evolved. They essentially compared two eras of their practice. Group A was the earlier cohort of 312 cases without routine buttressing, and Group B consisted of 856 cases where routine rigid sellar floor reconstruction was implemented starting in January 2009.
And the variety of pathologies they treated is quite broad. While 63.4% were pituitary neuroendocrine tumors, or PNET, they also included Rathke's cleft cysts, craniopharyngiomas, chordomas, and even inflammatory lesions.
What's striking about this paper isn't just the how of the reconstruction, but the why. They ground their technique in a specific physiological concept, the water hammer effect. Alara, walk us through how the authors define that in the context of the sella.
It's a compelling rationale. The authors argue that because the sellar floor is originally osseous, made of bone, it should be reconstructed with a rigid material. The water hammer effect refers to the pulsatile nature of CSF pressure. If you only use soft materials for reconstruction, like fat grafts or collagen sponges, that pulsatile pressure acts like a repeated hammer blow against the closure.
Right. Without a rigid buttress, those soft materials can shift, or the dural seal can be compromised over time by that constant oscillation. The rigid reconstruction acts as a counterforce to that pressure.
Exactly. They mentioned that when they used calcium phosphate cement in the early stages of the study, they noticed that if the cement didn't adequately solidify, leaks occurred. But when it was hard, the leak was prevented. This led them to standardize the hard buttress approach.
Let's talk about the materials they used for that buttress. In Group B, they used a few different things: autologous bone grafts, calcium phosphate cement, titanium mesh, and resorbable fixation plates, specifically Lactosorb.
Among those, the autologous bone graft harvested from the nasal cavity, which the paper notes was previously discarded tissue, proved to be the most reliable. They used it in 781 cases.
It's the ultimate reduce, reuse, recycle in the OR, but they did note some drawbacks with the other materials, didn't they?
They did. Calcium phosphate cement occasionally caused inflammatory changes or graft dislodgement. Titanium mesh, while rigid, tended to complicate things if the patient needed a reoperation later because it's difficult to remove or work around.
That's a great pearl for the residents listening. Always think about the next surgeon, who might be you. If you're putting in a permanent metal mesh, you're creating a barrier for any future transsphenoidal access.
Now, looking at the results, this is where the data gets really interesting. They used a multi-layer closure strategy: dural suturing, the rigid sellar floor reconstruction, and a vascularized sphenoid sinus mucosal flap.
And the numbers for postoperative leaks?
This is the headline. Postoperative CSF leakage requiring reoperation was significantly reduced from 2.88% in Group A, the era before routine buttressing, to just 0.47% in Group B. That's a p-value of 0.002.
That is a massive drop, especially when you consider that Group B actually had a higher rate of intraoperative leaks.
That was the most surprising part of the paper for me. The intraoperative leak rate in Group B was 76.5%, compared to only 54.2% in Group A. And even more specifically, Grade 3 leaks, those large high-flow leaks, were much more common in Group B, at 30.4% versus 11.2% in the earlier group.
Now, for the residents listening, why would a more modern cohort have more intraoperative leaks?
The authors suggest it's because of more aggressive tumor removal and more extended transsphenoidal approaches. As we've become more comfortable with the anatomy and the endoscope, we're pushing further into the suprasellar and parasellar spaces, which naturally increases the risk of opening the arachnoid.
Exactly. We're being more ambitious. But despite being more aggressive and having more intraoperative leaks, their postoperative failure rate plummeted because of the rigid reconstruction. It shows that a high-grade intraoperative leak doesn't have to mean a postoperative complication if the reconstruction is sound.
It's also worth noting their institutional policy on handling suspected postoperative leaks. They don't do conservative management.
Right. They mentioned that if a postoperative leak was suspected, they didn't use lumbar drainage or prolonged bed rest. They went straight back to the OR for surgical repair.
And in those rare cases in Group B where the reconstruction failed, those 0.47%, the authors were very honest. They stated that all those postoperative leaks were attributable to inadequate buttressing.
Which really reinforces their thesis. If the buttress isn't firm or doesn't cover the entire defect, that water hammer effect will find the path of least resistance.
Dr. Aris, for a resident in the scrub sink getting ready for a peanut case, how should they visualize this rigid reconstruction based on this paper?
You want to restore the native barrier anatomy as closely as possible. Think of it as a three-layered defense. First, you have your dural suture, closing the door. Second, you have the rigid buttress, the hard Sellar floor, which provides the structural integrity to withstand that pulsatile CSF pressure. And third, you have the vascularized mucosal flap, which provides the biological seal and blood supply for healing.
The authors emphasize that this isn't just about one technique, but an integrated mechanism-based approach. They believe this strategy can actually shorten the learning curve for TSS.
I agree. It moves the conversation away from, I hope this fat graft stays in place, to a mechanical engineering solution. If you understand the physics of the water hammer effect, you realize that soft packing alone is often insufficient for high-grade leaks.
They also mentioned that they performed this rigid reconstruction regardless of the tumor type or even the presence of an intraoperative leak.
That's an important point. They call it routine rigid reconstruction. Even if you don't see CSF during the case, subtle fistulas or occult leaks can manifest postoperatively once the patient starts straining, coughing, or just moving around. By reconstructing the floor rigidly every time, you're preemptively neutralizing that water hammer effect.
Before we wrap up, let's touch on the follow-up. They followed these patients for at least 1 year, and all the postoperative leak events they did see occurred within the first month. So this technique seems to provide both immediate and stable long-term protection.
It's a powerful study. 1,168 cases is a lifetime of work for many surgeons. To see a reoperation rate for CSF leaks drop below 0.5% in the setting of more complex extended cases is a testament to the hard buttress philosophy.
Absolutely. It really highlights that as our surgical approaches become more extensive, our reconstruction techniques must become more sophisticated and physiologically grounded.
Well, that's all the time we have for today's deep dive. I want to thank Dr. Alara for breaking down the data with me.
It was a pleasure.
To our listeners, residents, and colleagues, keep this water hammer effect in mind next time you're closing a sella. A little bit of nasal bone might be the difference between a routine recovery and a trip back to the OR.
Thanks for tuning in to the Neurosurgery Hub podcast. We'll see you in the next episode.
Stay sharp.